Our guest is Dr. Glenn Crotty. Dr. Crotty is the president and CEO of CAMC Hospital. And it's a pleasure having you back on the show, Dr. Crotty.
Thank you, Dr. Rashid. It's a pleasure being here.
Been a long time, but our topic is the Vandalia CAMC hospital system. What is the Vandalia health system, and how does it differ from what all of us in this area have known as CAMC? Let me make a comment. There's been so many changes recently in medical care in this city and county that the public is not aware enough of it. And that's why we're here today, to tell them what they need to know. So what's the difference?
Well, thank you very much for giving me the opportunity to talk to you about the Vandalia health system. Vandalia name came from the British back before the Revolutionary War. This area was supposed to be the 14th colony, and then the Revolutionary War got in the way and never materialized. We picked the name because it was more than just a West Virginia name. It was the regional name, because when we put some of those mergers together, we had operations in Maryland, Pennsylvania, Virginia, and needed a name that would transcend just the name West Virginia because of the geographic region. And we have merged together 14 hospitals across the state and covered 2/3 of the state with medical care facilities, both outpatient and inpatient.
And that covers about 130,000 people right now.
Well, that's in the health network. We have 130,000 people in the health network that we provide and support preventative care services, improve their nutrition, counseling, education, to improve the health of the people of West Virginia.
Okay, now, just from the average patient in our population here around Charleston, it looked like it was just overnight we had these two major changes in the health system in our area. Was it that quick?
It was pretty quick. We started in January of 22 of talking with the Mon Health System. Mon Health System has 4 hospitals, and they were members of the partners of the Physicians Health Network that we have, West Virginia Physicians Health Network. And we continued talking about what more things we could do together across the state. And we didn't have operations in the northern part of the state, so this was a perfect fit for our health network. And by September of 22, we suddenly grew from 4 hospitals in Charleston to 8 hospitals in the state. And then we added others.
So that was a very timely thing. It wasn't really as quick as it looked like from the public. One night we're CMC, and the next morning we're Vandalia.
Now, we've been talking, they've been members of the Physicians Health Network for some time, and continue to work with us, and it just sort of materialized in January, February of 22 as we should become a little more serious about merging together.
Well, that's important then. So we've got the merger now. Is it working?
The merger is working very well. We've added Greenbrier Valley Hospital in January of 23. We added Plateau Medical Center from Community Health Systems out of Nashville were the owners of Greenbrier Valley and Plateau. And we added Plateau in April of 23. And this continued to help us grow our services in those areas. And it helped them by supporting care locally. So we were able to recruit some physicians for those areas. We were able to stabilize the nursing situation. We were able to work collaboratively in installing the information services to both technology to Greenbrier Valley, and we'll have Plateau on the same electronic health record by July. So it's helping us to connect information, it's helping us connect services, it's helping us to provide support to those areas. Not only live support, but telemedicine support.
Well, now that's very interesting. So when you're putting those many systems together, there's a whole lot of things. Are there any current issues, or what was one of the most problematic things? I'm thinking about computers and AI and all like that.
Oh, the computers is the toughest system. We're almost finished with connecting everybody on the same human resources platform, the same supply chain ordering platform, the same accounting platform. So we will have the same accounting platform, human resources platform, supply chain ordering platform across all of our hospitals in Vandalia. And we're working with the pharmacy groups in all of those areas to work toward a single formulary, single purchasing piece. We're working toward a common group purchasing organization to save money on the cost of drugs and supplies and commodity items like gloves and toilet paper and batteries and things like that.
So this is working, but I'm hearing now this is actually going to be a relatively cost-saving situation.
It will. It will reduce the costs because the biggest enemy of any hospital is inflation. Inflation goes up 3% per year, and with inflation, we have to be able to cut costs each year to make up for inflation.
Well, not only that, if you're having to have several orders or batches, I would think there could be a supply problem, such as with COVID. You may not be able to get what you need in a timely fashion.
That's correct. And there are close to 300 drugs at any one time that have been in short supply or not able to be manufactured because they had a plant destroyed by the hurricane in Puerto Rico, or they had a plant fire in Kansas City, or any one of these kind of things creates a major issue. But that's why we work with the group purchasing organization on a common platform to be able to help support us in finding these scarce resources when they become scarce.
So the more you can order, the less costly it's going to be, as in any business.
Yes.
Now we have the problem, 90%, is it, or something like that, of our medicines used in this country are made in India or China.
That's correct.
And they don't have to go to war. They can just supply us with their opium and decrease our supply of medicines and devastate this country.
Well, it's a challenge, and hopefully the U.S. government is working with the manufacturers to create more manufacturing of pharmaceutical products in the United States.
I'm glad you're working on that. Now, you talked about all of these connections and on doing these things. Has this, when you did the computer systems and all, has this helped the patient portals?
We were working on a new patient portal through a product we're adding to our Cerner system that is live in some of our locations and will be more supplied to patients in locations by the summer. But its ability to do online scheduling. You can schedule your own appointment. You can communicate with your office electronically rather than having to call on the phone. We have a patient portal, and Oracle, who bought Cerner, is creating a brand new portal that we should have by the fall.
Well, I know as a patient that they'll sometimes send me my appointments by email or on my phone. And sometimes, though, if you dial directly, you've got to go through the system, so to speak, and you have to listen to that thing.
Yes.
And sometimes you can get around it, but it's a little different. When you call for your doctor or you've been referred to a doctor by your doctor, then you go in, all of a sudden you're seeing a physician's assistant, not necessarily the doctor. Now, these are very capable people, but a lot of our public aren't aware of what a physician assistant is and the training they have. It's extensive.
Yes, it is.
And so this is a problem. Are you having trouble finding doctors and nurses and physicians assistants?
We are.
Every hospital.
Every hospital is having that. There are 200,000 physicians short in manpower across the country. There are 200,000-300,000 nurses short across the country. Physicians assistants, they're short. And we keep recruiting, we keep training, and are working on programs to specifically train advanced practice individuals in the acute hospital settings, like for ICU and cardiology and things like that.
Well, in the old days, we had Philippi was training physicians assistants. Remember that? And then they closed that facility down. I guess they financially they couldn't make it.
Yes.
But that's been around for a long time. They did a great job. I don't know of any other specific school in the state that's training physicians assistants.
UC has a training program for physicians assistants.
Really?
They have about 15 students a year, and we hope to be able, working with UC, to be able to increase that.
Well, I have to talk to them about that. I talked to them about it when they started their pharmacy program over there. And we've been a long supporter of them. Now, you have two major systems, but right now we're talking about CAMC. Is CAMC the only head trauma?
CMC is a level 1 trauma center, and to be a level 1 trauma center, you have to have all the physician services needed, on-site trauma surgeons, orthopedic trauma surgeons, ENT, ophthalmology, plastics, urology. You have to have the whole breadth of subspecialty services.
And they're on call 24 hours, 7 days a week.
7 days a week. And there are two level 1 trauma centers in the state.
Yeah.
Western University in the north at Ruby and CMC in the south. Huntington has a level 2 trauma center that is shared between Cabell and St. Mary's.
Yeah, my son-in-law, Dr. Bound, works with them there. What major problems do you see in the future as to what facilities are necessary. Oh, let's go a different way. We know that you are stressing certain things now. So what are the specialties you're looking at? I know cardiovascular is a big deal, and I know urology is. My 94-year-old sister, about 3 weeks ago, had aortic valve surgery. She had to relax that first night in the hospital. The next day she relaxed, and she's up and around and going. We can't keep track of it. It's just amazing. And Thomas did, I think, their first open heart surgery last month.
Yes.
So both systems are looking at cardiovascular.
Well, this area is an indigenous area for cardiovascular disease.
I thought you'd bring that up.
There's just an amazing number of amount of cardiovascular illness.
Well, in the urology part too, that is, they have a lot of problems with aging people, men and women. And so this is a big deal. They're doing some special things at CAMC now. Dr. Laurie is doing some.
He's doing incontinence surgery.
Yes.
And Dr. Deem is doing ultrasound treatment of prostate cancer. But we have advanced robotic equipment. There are 4 robots at Memorial, including a single port robot that you can do things simpler, easier, and patients recover much quicker. Most patients go home the same day.
So even the robotic surgery has improved that much?
It has. It is just absolutely amazing what these gentlemen can do and ladies can do with the robotic surgery. We're adding one to the general. We have 2 at Women's and Children's, and we're even adding a robot to the simulation center so residents can go and practice in the simulation center and improve their skills at robotic surgery while they're still a resident.
Now, can they update the robotic instruments we had before and make them better, or do you have to buy new ones every time there's a change?
We try not to make too many changes, but when you buy new sets of equipment, you have to update the products that service that equipment.
And new training.
And train them.
And new training. Yeah, it's like the eye instruments they cost a fortune. So every general surgeon doesn't do robotic surgery. Is that correct?
That's correct. We have some that do robotic surgery and some that don't. And not every case is appropriate for robotic surgery, especially emergency surgeries are not truly appropriate for the robotic method.
Is robotic surgery more expensive for the hospital and the patient?
A little bit, yes. The devices and the supplies that support the robotic procedure are more expensive, but
time
and recovery.
Yeah, that would make a big difference because one of the costs, of course, is having to put people out and keep them in the hospital. So that's very understandable. Are there any other special procedures you guys are looking at in certain departments where you're trying to update or who are already updated?
Well, we have the only 2 endovascular neurosurgeons in the state. They do a lot of catheter procedures to take care of aneurysms and AV malformations and pull clots out of cerebral arteries and do very fancy work. We're adding a new hybrid suite at the general to support the endovascular neurosurgeons. We have interventional radiologists now that are ablating lesions in the liver for tumor.
These are the radiology oncologists.
Yes.
Yeah.
And they do multiple fancy things with catheters, remove clots, do fibroid surgery, and do fancy biopsies and get to areas that normally you can't get to. But they have a new piece of equipment that has a CT scan and a vascular lab C-arm table that you can pinpoint exactly where lesions are in the periphery of the lung, for instance, or deep in the liver, that you can get to and ensure that you get the biopsies needed and the right tissue to support their care.
Well, what doctor was talking about was this, let's say somebody has a stroke and there's a clot in a main blood vessel. A stroke can happen two ways, a clot, or there can be an actual hemorrhage and a rupture. They can pass the cannulas through the arteries or the veins and locate that, and they can either chop it up or suck that clot out. It's just amazing what they're doing. It's like Mitchell does when he's doing his cardiology and opens up for the heart. They're doing so much now. It's just amazing.
Well, they're also doing, the cardiologists are now doing hypertension treatment with renovascular deinnervation, putting catheters in the kidney, and lowering the pressure and lowering some of the adrenergic supply to the kidney that lowers blood pressure and helps patients control their blood pressure or get off of blood pressure medicine.
And also decreases the number of people that end up on dialysis.
That's correct.
And dialysis is a big deal now. I can't imagine how many dialysis places there are in the state now.
Well,
it's amazing.
It is absolutely amazing. And one of the cardiologists, we're getting an additional structural heart physician that puts in these valves through the catheters.
The pig valves?
The big valves, the aortic, the mitral. They're putting clips, mitral clips on just to repair mitral valves so it quits leaking, and they block off left atrial appendages that prevent clots from gathering in the heart, so that prevents people from getting strokes. And we're adding another physician. We're bringing in an additional cardiovascular surgeon who will be here in August. And
we'll look forward to having them on Vital Signs.
Oh, he would be wonderful for you to have on Vital Signs. And the advancements in imaging, we have one of the world-class imagers, cardiology imagers here, and Dr. Reinhardt. She does cardiac MRI, cardiac CT. She does three-dimensional angiograms with a CT scanner, and they do a heart flow study on this to tell you which areas are the most critical to fix through a stent or bypass. And they can tell you if the lesion is critically blocked or not critically blocked by the flow without having to do a catheterization.
So they can be selective now.
Very selective.
In the old days, we used to have to just treat the symptoms and what it was, and we couldn't always select what we wanted to do or needed to do. We didn't always know what needed to be done.
Well, if you go back a few years, when CMC was doing 3,000 bypass procedures a year in the days of Con and Con, we didn't have stents. We barely had angiography, where Hal Sellinger brought angiography to CMC, where you could put dye in the artery and take pictures of the heart. And then they developed stents that helped open the vessels, balloons and stents, where the stents kept the vessel open, so we didn't have to do as many heart surgeries. And we're down to about 1,000 open heart procedures a year.
But when Doctor was doing those, Jamil, is that correct? Yeah.
Jamal Khan.
Yeah, when Dr. Khan was doing those, he was doing cases no one else would touch. He was a magician.
He was amazing. He and Z were just absolutely unbelievably talented.
So we're working on building up certain specialties. We're looking for the new specialists, and that means you're going to have to start searching for some more doctors. And maybe you need to have more parking space. Are you going to talk about the parking space? It's free now.
Parking is free at CMC, yes. We have figured out that our employees are not going to park in the spaces needed for patients. And we were so worried that we wouldn't have places for patients to park. So we have finally, volunteers kept asking us as well all the time, when are you going to have free parking? So in November, we've had free parking at CMC since that time.
Now, another thing we should talk about, I know literally yesterday, I was talking to Kelly Anderson about the volunteers. She's been on our program before. Most people don't realize how important the volunteer services are to a hospital. I have a brochure here. They literally have some of these people that have had thousands of hours of donating their time. It's just amazing. And you're going to give me what would it cost to supplement or have to pay for all those volunteers' services?
For all the hours that we have had, it would be about $780,000 in free services.
A year?
A year.
Golly. Dr. Crotty, I want to thank you so much for taking your time to be with us today. Many people may wonder why he talked about being a doctor. He was a doctor a long time before he became the CEO. This is Dr. Richard C. Rashid, hoping you'll see a bright day.